Okay, I might make a start now. Good evening, everyone, and welcome to the Shared Vision Falls Prevention for Community Eye Health Practitioners webinar. My name is Balana, and I'm the Injury Prevention Officer for Workforce Engagement at Injury Matters. Today, we have Jingyi Chen who will be delivering this webinar. Before we begin, please let me acknowledge the Whadjuk Noongar people, who are the traditional custodians of the land on which Injury Matters work, and recognise Aboriginal and Torres Strait Islander peoples' continuing connection to the land, waters and community across Western Australia and Australia. I would also like to acknowledge the traditional custodians of the land in which you are joining in from today. Please use the chat box to let us know where you're joining in from. Before we start, I'd like to go over a few housekeeping points. You will notice your microphone is muted. This will allow all attendees to hear clearly. However, we would still love to hear your questions, so we strongly encourage you to please send them through in the chat box throughout the presentation and we'll go through them at the end. If you have more than one person in the room with you listening to today's webinar, we would appreciate it if you could please let us know via the chat tab to let us know how many people are listening in with you. If you face any technical issues during the presentation, please write them in the chat box as well, and we'll do our best to help you. I have Suzanne here helping me this evening. We will also have a QR code at the end of this presentation so you can complete a short evaluation on this webinar. If you could keep that in the back of your mind, that would be great. Please note that Injury Matters prohibits the use of artificial intelligence-driven systems and technologies, such as automated note-taking, recording or transcription tools during or following this webinar. So, just about Injury Matters. At Injury Matters, our vision is for safer people and places. We aim to prevent and reduce the impact of injury within the Western Australian community and support those who have been affected by injury. Our three programs aim to raise awareness of injury risks, consequences and solutions, prevent injury through a range of education and support programs, and support the recovery of people, families and communities impacted by injury and trauma. This training is brought to you through our Stay on Your Feet program with the support of the WA Department of Health. The Stay on Your Feet program provides information, training and support to older adult community members and professionals working with older adults on how to prevent falls in the community. The Stay on Your Feet has three key messages that we use throughout our campaign and community and workforce engagement. These three messages are move your body, improve your health and remove hazards. And this is where we get our overarching slogan, move, improve, remove. Falls are a significant public health issue in WA. It is seen that 1 in 3 people over the age of 65 fall each year. The 2024 WA Falls Report highlights that in WA someone dies every 17 hours, is hospitalised every 16 minutes, and presents to the emergency department every 12 minutes due to a falls-related incident. Falls can result in a real impact on an individual's life that can lead to a loss of independence and confidence, increased concern of falling, and difficulty doing daily tasks. As people age, it is common for their visual function to decrease. However, this is associated with an increased risk of falling. It can be seen that older adults with vision impairments are twice as likely to fall than older adults without vision loss. Eye health practitioners play an important role in falls prevention among older adults in the community. I would now like to introduce Jingyi Chen, who will explore how eye health practitioners are involved in preventing falls. Jingyi Chen is a therapeutically endorsed optometrist, lecturer and PhD candidate at the University of Western Australia. Her research explores opportunities for the eye care workforce to meet the population needs, including how collaborative care and digital health can improve patient outcomes, reduce wait times and improve access to care. Please welcome Jingyi. I will now pass you on to her.
Thank you so much, Bilana, and thank you so much, everyone, for joining us on a Tuesday evening. It's so great to see you all. Before I begin, I also wanted to acknowledge the Noongar people and acknowledge that I'm joining from their land, acknowledge them as the cultural custodians of their land, and pay my respect to elders past and present. and I'd like to extend that to any Aboriginal and Torres Strait Islander people present today. So, as Balana said, I am an optometrist and I work at the Department of Optometry and Vision Sciences. And I'm really excited to bring to you some of our recent research findings and also give you some tips and insight into how you can use those research findings to improve your practice. So, the talk today will look at the role of eye care practitioners in falls prevention for older adults. Hopefully, by the end of this talk, you'll be able to apply the evidence based recommendations to your own eye examinations in the community and better understand the referral pathways and opportunities for collaboration, not just with each other, but also outside of eye care. So before we begin, I thought we would start with an interactive poll. So I wanted to ask you what you think the leading cause of injury hospitalisation is in Australia. So if you have your phone or a device nearby, please scan the QR code and choose which of the 4 options you think is the leading cause of injury. So do you think it's contact with objects such as sharp objects or machinery? Is it falls? Is it transport, which includes motor vehicle accidents, or maybe it's burns? Okay, so everyone was obviously listening when Balana introduced the talk earlier. So falls are the leading cause of injury hospitalisations and injury deaths in Australia. So this obviously is a huge public health problem, especially around the world, as we look at the ageing population. The personal cost of falls is obviously devastating. People who fall, it can lead to disability, a loss of independence, for example, fear of falling, so people are less willing to go out, and of course, death. But also to the health system, it comes at a significant cost. So in Western Australia, falls related injuries cost $267 million per year, and around Australia, $2.3 billion per year. But falls are not just accidents. There's actually a wide number of risk factors for falls. And we understand that it's not just the individual, but it's also the environment that they live in, as well as the activities that they're doing. And because of extensive research, we understand that there are a number of risk factors, both intrinsic and extrinsic to falls. And interestingly enough, as eye health practitioners, we actually get insight into a large number of the intrinsic risk factors. Age and sex we know before the patient even walks through our door. We get a very good understanding of a patient's systemic health conditions and the medications they use, as well as how many they use, because if they use more than 4, that increases their risk of a fall. If we ask, we know about a history of a patient falling, and of course, we know visual impairment incredibly well. So now I'd like to talk a little bit more about the link between vision and falls. So we know that vision loss is very prevalent in older adults, and as Bilana said, the risk of falls increases by twice as much when a person has a visual impairment, and the risk of hip fractures increases by 4 to 8 times. Only about 20% of Australians who need visual impairment low vision services actually receive those, but up to 90% of people could benefit. So you can see there's a huge gap there in terms of who is actually are able to benefit from these services versus who's actually receiving them. And as eye health practitioners who are either the provider or the referrer for these services, this is a gap that we definitely need to address. So, in terms of our role and our everyday practice, I just wanted you to consider for a moment whether this has ever happened. So, have you ever had an older person attend your practice? And majority would say yes. So, world statistics shows that 1 in 4 older people fall each year. But in WA, as Balana said, 1 in 3 fall each year. So, even without any of those other risk factors that we saw in the table, just having an older person attend your practice means that that person is at risk of a fall. Have you ever had an older person come in because they broke their glasses because they recently had a fall? That has definitely happened to me. And have you ever been testing a patient and they said that they had a fall recently casually when you didn't even ask? And this is another really common scenario that we face. And often we express our empathy and sympathy. We say, I'm so sorry to hear that. But that's often where the conversation ends. So, a person who's had a fall is twice as likely to fall again, which places them at moderate to high risk of falling. And that's something that should be in our minds when we're assessing our patients. So, because of how many older adults we see in the community, we actually have an excellent opportunity for falls prevention. The reasons we want to do this is, of course, the public health aspect and the social impact. We all know an older person that would be devastated if they had a fall and suffered the consequences. It's also potentially a specialty interest area for optometrists to get involved in and a point of difference for your practice. And you might increase your number of referrals or patients attending because of that. And it's also an ideal way for us as eye health practitioners to become part of the broader healthcare system. So, historically, eye health practitioners have always been a little bit siloed when it comes to referrals and working with each other. Orthoptists, optometrists, ophthalmologists work really well together, but in terms of working with other health professions, we're not quite as good at that. So, falls prevention is a great way for us to integrate better in interdisciplinary care and with the broader health system. So, my colleagues and I recently published a scoping review looking at the evidence for eye care practitioners in the community, whether they were aware of falls prevention, whether they implement any of those behaviours in practice, and whether there were any barriers and enablers to doing so. Here's a summary of what we found. So, overall, most eye care practitioners are very well aware of the link between visual impairment and falls risk, although some more awareness would probably be beneficial. There were quite a few key gaps in terms of implementation of falls evidence. So, there were examples of eye care practitioners being aware of, say, referring a patient to an occupational therapist for home modification and knowing that it's a good thing to do, but not actually doing it in practice. A lot of eye care practitioners are very good at giving advice to patients about adapting to multifocals, but a lot of that motivation for prescribing multifocals and prescribing changes was not to do with falls, but more to do with personal experience. So, for example, if a patient had a really large change to their glasses prescription, a lot of eye care practitioners would think about reducing that change, not for falls, but for potentially lowering remakes. But overall, there was a big sense that there is not enough being done in community and that eye care practitioners in general would benefit from more understanding of falls. So the barriers reported, number one was time constraints. So practitioners were worried that there wasn't time to do history taking or organise referrals. There were concerns that referring a patient to low vision clinic might actually increase their fear of vision loss. There was overall a lack of training and awareness and unfamiliarity. There weren't that many enablers reported in the literature. One suggestion was to add a prompt or a reminder on an electronic health record to prompt the optometrist, ophthalmologist, orthoptist that falls recommendation was needed. But I think the reality is that it's very tricky to modify an EHR. And so that sort of wasn't taken up in practice. Another paper that we published recently was on rural eye care. And so, rural eye care, of course, adds another layer of complexity when it comes to providing eye care services. And this paper was a qualitative study. So, we did interviews with members of the eye care workforce in rural and remote Western Australia to seek their perspectives on care provision and where the opportunities were. So we interviewed 17 participants in all regions of rural and remote Western Australia, and this included optometrists, ophthalmologists, and non-clinicians as well. And we found four major themes to do with rural eye care provision. The first was the motivation to work in rural settings. So rural practitioners spoke about the increased scope of practice and large amount of pathology that they encountered in everyday practice. And also, interestingly, of course, because of the smaller rural areas, it was actually easier to do interdisciplinary care compared to if they were in a city, because it was easier to form those meaningful connections with each other. And so what we often find is that practitioners in metropolitan settings actually find it more difficult to refer potentially interdisciplinary, because there's less opportunities for them to find out about the services. Of course, there are challenges of working in rural areas as well, such as when referring, there was a lack of established channel for communication. And this was especially an issue when referring to public eye clinics, with optometrists sometimes finding that referring a patient meant that they weren't sure how the referral was going. However, because of, I guess, technological advancements, hopefully this will improve over time. Access to care is obviously quite a huge issue for rural patients, with increased travel and distance required to access eye care services because of limited local services. But this brought into or showed us the importance of collaboration. And so when we interviewed participants from different areas of Western Australia, we found that there was quite a bit of variation in the extent of collaboration, very much due to their location and the person dependent systems there. But it was promising to see good relationships between referrers and referees. And I think that there was quite a lot of mutual trust and respect between professions. And I think that brings us back into falls prevention and the importance of collaboration to deliver best patient outcomes. So often eye care practitioners do wonder, what can I do for falls prevention as an eye care practitioner? Obviously, we're aware of GPs, physiotherapists, and occupational therapists playing a huge role. But as an optometrist or ophthalmologist, what can I do? There's also, of course, the question of, do I even have time to do falls prevention? Because I'm already seeing a patient, trying to do all my eye test things. How can I then find time to do falls prevention on top of that? So before I share with you some tips, I wanted to ask, are you aware of any falls related guidelines for eye care practitioners? So if you wouldn't mind scanning the QR code again, I'd be really interested to see how many of you have come across or heard of any guidelines for falls prevention. So about 2/3 of you have, which is really good, and about 1/3 hasn't, and that's okay, because I'm about to share with you some guidelines. So the World Falls Guidelines are probably less known to eye care practitioners, but they were published in 2022, and this was a huge global effort, summarizing all of the evidence-based recommendations for falls prevention for all healthcare practitioners, and ranking them based on strength of evidence. And so this paper included eye health specific recommendations, which I'll discuss in a moment. On a more local level, Optometry Australia also has guidelines for falls, and this was published in 2019. And the guidelines were designed for educating optometrists on how to prescribe and for patient management. And so if you haven't come across this guideline before, I've included the QR code for you to scan and have a look in your own time. So I've looked at the Optometry Australia guidelines as well as lower four guidelines, and the next few slides are to talk about sort of a combination of the two. So going back to a typical clinical exam, history taking is typically the first step. And often we already know, as I said, the age. We often ask about the medications that the patient is taking, and we also ask about what their current spectacles are. But starting falls prevention in your clinical practice literally can take 5 seconds. And that starts with asking an additional question in your history, which is, have you had a previous fall in the last 12 months? So, as we know, the risk of falling again is twice as much if the patient has fallen before. And so asking a simple question already gives you so much insight into the risk of that patient's profile. Another question we could ask is, when do you wear your specs? And so asking them which pair of glasses do you wear when walking around can be really useful, because patients are often reported to either not wear their proper glasses or they're wearing the wrong pair. And so if the patient says, oh, I don't know, I just grab whichever, and sometimes I end up walking around with my reading glasses on, you immediately know that there needs to be some education around this, because their risk of falls is going to be much greater if they're wearing the wrong pair of glasses. So, in terms of time constraints, these two questions probably won't take more than 1 minute, and is a great way to get started thinking about falls prevention in practice. In terms of the clinical examination recommendations, the first is visual acuity, again, something we're extremely familiar with. And of course, we understand that the worse the visual acuity is, the more likely the patient is to fall. And so, especially if the vision is worse than 612 or 615, classifying them as unable to drive or low vision. Depth perception, though, or stereo, is something that we typically assess quite a lot on children when we're trying to see how their visual development is, assessing for amblyopia, but something that we often overlook when it comes to older adults. But of course, depth perception is extremely important when people are walking around, making sure that they're able to see curbs and stepping over things. When they've lost that depth perception, it can be really, really difficult. And so this is something that you should consider implementing into your practice, especially if the patient has come in reporting a previous fall. Another test that we often talk about but don't do as often is contrast sensitivity. And I think everyone is aware of the link between contrast sensitivity and the limitations that we have always measuring vision with a high contrast chart with black letters on a white screen. And so contrast sensitivity is another area where you should be measuring that in patients, especially when they're at risk of a fall. And again, visual field is something we already do and understand really well in clinical practice, but especially for patients with an inferior visual field loss, such as patients with optic neuropathy or glaucoma, it's important to consider that, because inferior field is often where patients are looking down when they're walking. And having that field loss means that they're more likely to trip over a hazard. And of course, for hemianopia and other visual defects, it's very, very important to take that into consideration as well. So now that we know that the patient is potentially at moderate to high risk of falling, how does that then inform our management? And again, this is something that we already do in practice, but it's just another thing to think about when you're deciding on the best management options for a patient. So the recommendation from OA is to prescribe small refractive changes. Of course, spherical is really important for magnification, but be really careful with axis changes, especially when the vision doesn't improve that much with a big axis change, because that can make it very, very difficult for patients to adapt. Also be careful with monovision, because again, that reduces stereopsis or depth perception. And so maybe don't put one of your older patients into monovision contact lenses for the first time. And if you must, maybe consider a smaller amount of difference between the eyes. And a way to get around this is potentially doing more frequent reviews. So instead of prescribing the full amount in one go, you might want to prescribe a small amount. And again, this is something that optometrists already do in practice, not so much for falls prevention, but just to help the patient adapt. But it's something really important to think about. Of course, providing advice on adapting to new spectacles. So if you must prescribe the change, educating them on what to expect and being careful with regards specifically to falls. The evidence actually suggests that single vision distance spectacles are better to be worn outdoors rather than bifocals or multifocals. And this is often met with resistance from patients, because they would prefer to have one pair that does everything, as we know. But This might be really important to mention to your patient, especially if they've already had a fall and they were wearing a bifocal or multifocal. And this is regardless of how used to it they are. So one way you might want to overcome this is you could recommend the use of a second pair of single vision distance glasses, maybe with sunglasses or with transitions, and just explaining the evidence behind that. And of course, if they must wear multifocals, if they do wear multifocals for indoor tasks and things like that, advice on wearing them, such as educating them about the blur at the bottom, again, a trip hazard. And this is again something that I think most practitioners do very well for the first pair of multifocals, but then we just assume that patients know how to use them. And when you see a patient who's at high risk of falls, I think it's very worthwhile to remind them of this advice, even though you assume they already know. In terms of other management considerations, cataract surgery has quite a strong evidence base behind it. So, of course, if a patient is borderline for cataract surgery referral and they're at high risk of falls, the recommendation is to refer them a little bit earlier. The same goes for the second eye. So, of course, if you've got a patient who has ended up with anisometropia after cataract surgery, then you would consider referring them sooner for the second eye rather than waiting for it to get worse, just because that difference in time can cause a fall, just because of the difference between magnification of the eyes. Now, the evidence is interesting because there's some studies that have said that cataract surgery potentially increases the risk of a fall, but a lot of that is attributed to the magnification changes. And that's where the post cataract surgery spectacles is often something, again, that we need to think of. So, if there's a very big difference between the eyes, potentially decreasing that or referring earlier for that second eye cataract surgery. And lastly, another management option that we do need to consider is referring to occupational therapy. So the evidence suggests that a patient with visual impairment should be referred to OT for home environment assessment and to remove things like trip hazards. And so this is particularly important for our low vision patients. And I do urge you, if you do have a patient with low vision, to have that conversation with them again, because it's not just magnification devices that they can get, but also referrals to OT as well. And so this is something that will happen outside of the consult room for eye health practitioners, but it's something that we should be thinking of because we have the ability to refer patients to something. So, in terms of referring to OT, it's very scary sometimes to refer outside of the typical. If you are an optometrist, for example, referring to someone who's not an ophthalmologist or a GP, because there are so many referral pathways and it's very confusing. But there is a resource called Clinician Assist WA, and I'm not sure how many of you know of this already, but this website you can register for as a healthcare professional, and it's designed for GPs and other health professionals to educate and guide referring patients across WA. So previously, Health Pathways WA was what was used, and this is the system that has replaced it. So all you need is your ARPA registration to join. So I've popped the QR code on the right-hand side there as well. So as you can see on the website, on the left-hand side, there are a number of different health professions, including optometry, that can be found. And as an example here, I've included OT. And so when you click into each of the professions, you can read more about the services that are provided and how the referrals actually work and any referral criteria that exists. So there's quite a lot of evidence behind OT, of course, but there's also quite a lot of evidence behind exercise for patients for falls prevention. And so if that does come up and the patient wants a referral from you as an optometrist, then this is potentially an avenue that you can explore. So as a summary for everything we've discussed so far, we understand now that falls are a serious public health issue, causing more injuries than motor vehicle accidents per year, which often is a surprising fact for people. And optometrists, ophthalmologists, and orthoptists are very, very well positioned to provide falls prevention advice to older adults because of how many we encounter each day. I hope I've also demonstrated to you that falls prevention is very possible in community settings. And although time is often seen as a barrier, it's, as you can see, asking a simple history question, have you had a fall in the last 12 months? Asking about when they wear their glasses, thinking about stereopsis and monovision, and thinking about your prescribing and your education for the patient can make a huge impact. And of course, referring to OT for people who have low vision. And so you can see there are many opportunities for us as eye care professionals to make a positive impact that might change the patient's life. And so I would highly encourage you to think about how you might want to implement some of these into your day-to-day setting. So I'd love to find out, how likely are you to start doing falls prevention in practice? And I know that some people do work in aged care here and who hopefully are already doing this in practice. But I think a lot of community practitioners do underestimate the impact that they can have just on a routine eye exam for an older adult who doesn't even talk to you about falls. And so I would love to know. Great. So it's great to see that some people are already doing falls prevention in practice. And that is exactly what the evidence has shown, is that people do have, I think, already have some awareness of how to do this. But for some practitioners, falls prevention has often been put off to the side, kind of as another health practitioner's job. And I would highly challenge you to reconsider that, because we as eye health practitioners have a huge opportunity to start tomorrow and to start asking. And you might be surprised with how many people that will come back to you and say, thank you so much for telling me about my multifocals, or for telling me to wear my single vision distance sunglasses outdoors. I didn't realize that that had such a big impact on falls. And again, if you haven't got access to the Optometry Australia guidelines, I've just added them here. It is very comprehensive, but if you scroll to the end, there are some very easy and quick guidelines for you to review. So I will shortly pass on the presentation back to Bilana to talk to us a little bit more about injury matters and the types of education and training that they can provide for us as healthcare practitioners. But I did want to acknowledge my co-authors and supervisors, Kaiba, Alison, Sharon, Sandy, Angus, Anne-Marie and Ben, some of whom have joined us tonight. I wanted to acknowledge the support from Injury Matters, as well as the support from Rural Health West and Lions Outback Vision. And if you have any questions at all, or if you wanted to discuss more about this, please feel free to email me. At the Department of Optometry and Vision Sciences, we are doing a number of research studies into falls. And so if you want to get more involved in the future, either as a participant for some of our studies or anything like that, please feel free to email us as well, and we can continue the conversation from there. And if you have any questions, as Delana said, please feel free to turn your mic on and we can have a chat, or you can pop them into, um,
Pop them in the chat box. That would be,
yeah, that would be
yeah,
good. Yeah,
yeah. Thank you. Thank you, Jingyi,
thank
for that
you.
really comprehensive webinar. I really enjoyed hearing all about the management strategies that you shared and all of the resources. It sounds like there are options for everyone. I'll quickly share my screen again. Oh, okay, so while we wait for those questions to roll in, we would really appreciate it if you could please complete a short evaluation on this webinar. Your feedback ensures that we're delivering sector support that meets your needs. If you do miss the QR code, we will have a link shared in the chat as well. So if you also wanted to share your questions or ask any questions, now's the time to do it. Okay, I'll give it a few more. Oh, here we go. Jingyi, how can we make falls prevention economically viable in community practice where time is money? Any thoughts?
Thank you so much, Kaiba, for that question. So I think this often comes up in community practice where practitioners feel I already have such limited time, and how do I incorporate more into my day-to-day practice? And so I think one one of the ways that we can think about this is that we are caring for our community. And I think that when you are able to, I think word of mouth is really, really important in terms of referrals. And I have personally seen the impact of me as a practitioner sharing more evidence for falls with patients and them saying, oh my goodness, this is so great. I've never actually had anyone talk to me about this before in my eye test. And often that can actually bring more referrals for their friends and colleagues who might come into your practice as well. As we discussed earlier, we also have opportunity for you to potentially be known as someone who has a specialty interest in falls. And so that's another way to make your practice stand out and be another stream of patients that might come through. And of course, I think hopefully I have managed to talk about the advantages to falls prevention, but also the small time commitment that you can weave into. It's not a huge eye test that you have to do separate to that. We already take a history. You just have to ask maybe 2 additional questions. We already do a visual acuity measurement. And you might want to test stereopsis and contrast sensitivity, which might take a couple of minutes. And the management, again, we already prescribe glasses. I guess just like other lifestyling considerations, when you do consider a patient's lifestyle, it allows you to make recommendations for prescribing based off that too. And so that's potentially another way when you're thinking about the economics of business and sort of what you do in practice that you can. So, for example, the single vision distance sunglasses being an additional recommendation that you could make to your patients that is backed up by evidence. Um, and if anyone else has any other insights as business owners that they wanted to share, I would love to hear that as well. Sarah asked a question. Thank you, Sarah. Do you know if Vision Australia also does OT or just visibility? So I believe that Vision Australia and WA has actually, as of this year, stopped providing client services directly, Sarah. And so I believe at the time of this presentation that it is just visibility for low vision services for client facing. But yes, Vision Australia has made a very big impact, and I have certainly referred to them in the past, but I believe as of now, they no longer provide those services to clients.
Thank you for those questions. Oh, here we go. Chelsea, just a thought for the group to consider for collecting information without affecting time. Could the extra questions be incorporated into a quick survey method when clients check into appointments?
Thanks, Chelsea. Yeah, that is a really great suggestion. I do know a lot of practices do a new patient form, or they might do a history form while the patient is waiting in the waiting room. And so if you already have that, then you can definitely add that prompt, especially if you're able to customize it and say the patient is over 60 or 65 years old. You can definitely include that question as a time saver. Another thing that I think would be worth exploring in private practice is if you have a training night or session that you can do with your front of house staff. And I think that this is really important because often when the patient walks in from outside and they've broken their glasses, the first point of contact is not the eye health practitioner, it's actually um, the clinic team. And so having them have an awareness of this is incredibly important because it might mean that they want to book them in for another eye health assessment, but also that they can provide some advice regarding falls prevention as well. And so I think having the entire team be on board and understanding the importance of this is actually really important. So that's another additional way that you could incorporate that without taking up extra time. But that's a great suggestion. Thank you, Chelsea.
Any last minute questions?
If anyone has any additional questions, please feel free to keep sending them and we can always come back to them later as well.
Okay, yep. Okay, so I will just move on now. Um, Thank you all for those questions and thank you for completing the evaluation. I'll now go through our Stay on Your Feet program and how you can be involved. So we have a suite of resources you can use in your workplace or with your clients. If you head to our Injury Matters website, you can find all of our resources available, which you can download and print off for free. We also offer 2 free self-paced online learning modules, the Introduction to Falls Prevention and Exercise Strategies and Screening for Falls Prevention online modules. And these provide professionals with background knowledge on falls, age-related changes, and how these can impact an individual's function, mobility, and falls risk. These modules can help you facilitate falls prevention exercise strategies as well. Um, and I'd now like to highlight the upcoming webinar that we have planned. On the 16th of July, we have the Preventing Falls in Older Australians, Applying the Updated National Guidelines in Practice webinar. This webinar will offer an overview of the updated guidelines, their development, and discuss applications across various care environments. You will hear from contributors involved in the development of these guidelines and gain insight into person-centered strategies to reduce falls risk and support healthy aging. You can register and read more about this event on our events page. Thank you again for taking the time to tune in to today's webinar and to Jingyi for sharing this information. Please connect with us. We're on various social channels. You can also sign up for our Falls Prevention newsletter and our Community Falls Network. Have a great evening.